to this episode of Joy's World, the podcast. Today I have another very special guest. I said on my podcast in the previous episode that I have had weight loss surgery. I had a gastric sleeve, and so I thought this episode, who better to help me explain what I went through and what I'm going to go through, my journey, than the surgeon that performed the surgery on me. And he goes by Mr. Ahmed. So Mr. Ahmed, welcome to my podcast.
Thank you, Joy. Nice to see you again.
Nice to see you too. Mr. Ahmed, I always start my podcast, but I always ask people the same question at the beginning, which is because I feel like it's very important to check in with people and how we're feeling. So I want to ask you, how are you today? And I don't just want, I'm fine. I want a real answer. Are you happy? Are you sad? Are you annoyed? How are you feeling?
No, I am actually happy as can be under the current situation with the COVID pandemic. But no, I'm happy. I'm happy I can do my job. I'm happy I can help people, and you know, we take every day as it comes. So no, thanks for asking.
No problem, Mr. Ahmed. Something I wanted to ask you actually was my second question to you is, how long have you actually been a bariatric surgeon for?
Oh gosh, okay. Well, that is a really good question. I would say for at least 16 years now, I've done bariatric surgery. But before that, I was sort of a general surgeon performing keyhole surgery. So I've always sort of specialized within the field of advanced keyhole surgery. And I still do a lot of general surgery as well, like hernias, gallbladders, so on and so forth. But to be honest with you, it was, I think, in 2005 that I sort of took up bariatric surgery as my main sort of specialty.
Okay, that's interesting. And I'm going to come back to that in a moment about how you got started and why you got started. But my next question to you actually is, can you describe being a surgeon in 3 words?
Exciting, fun, passion.
Okay, that's interesting. Those are all positive words, though.
Yes,
definitely. And so I was wondering actually, why did you decide to become a bariatric surgeon? Because you know, as someone obviously that struggled with their weight, hence why I've had surgery. Do you know, a lot of the times people are not kind to us, and so for you, I just wonder, how did you kind of get into thinking, oh, I want to be a bariatric surgeon, I want to do weight loss surgery for people? What was the process of that like?
That's a great question, Joy. So when I was a junior doctor and training in general surgery, my passion always, actually, let me go back even before that. So even before I went into medical school to study medicine, I always knew I wanted to be a surgeon, because I always liked working with my hands, and you know, it's always something that I really was interested in. I didn't want to be the kind of doctor who just sits and prescribes medicines for people. I wanted to be really in there and doing stuff with my hands. And during my training, so that's why I chose surgery in the first place. And then during my training in surgery back in the late 1990s, early 2000s, the sort of the keyhole approach, or we call it laparoscopic surgery, was really sort of becoming more and more common. And there was a great interest in England with laparoscopic and keyhole surgery to treat different conditions. And I kind of really enjoyed laparoscopic surgery because it kind of, you do the whole operation on a television screen. It's a bit like playing you could say, a computer game, just to give you an example. So I was really interested in laparoscopic surgery. And then I thought to myself, what can I really do that's going to help people really benefit from laparoscopic surgery? Because in those days, it was being done for hernias and gallbladders, but actually in England, very few, if any, people were doing it for weight loss. In fact, I would say nobody in early 2000 was doing it for weight loss. So I decided, you know what, it'd be a really good idea to use this technology where we have laparoscopic keyhole, sort of minimally invasive surgery, so you don't have to make any big cuts, in people who want to lose weight, they need to have weight loss surgery, because weight loss surgery has been around for decades, but it was done through open surgery. So people used to have big cuts and lots of, all the problems that come with having big cuts. So, the risk of getting wound infections and hernias, and the operations taking a long time to recover from, and a lot of pain. So I thought, why don't we adopt the keyhole surgery technology in the field of weight loss surgery? And that's sort of how I got into weight loss surgery. So then I went to the States. I spent a year in New York, in upstate New York, to learn from one of the top laparoscopic weight loss surgeons.
Okay.
And then I basically got headhunted to Imperial College London to set up the weight loss surgery unit here. So that's basically how I got into it.
Okay, that's interesting. And obviously you see patients all the time, every day. Do you often get to hear our story? So I know, like, when we have our consultation and things like that, you may hear little bits of, our struggles and things like that with our weight, hence to why we've reached this point. But do you have an interest in actually, understanding your patient stories, and how do you feel about that? How do you feel about diets in general as well?
Yeah. So it's a really, again, a very, very nice question, Joy. So every patient who comes to me for me to try and help them lose weight has their own story. Nobody's the same, but there are some common features in everybody's story, and it's important for me to work out, what has led to the weight gain, what has been tried before, to get a real understanding of, what kind of treatments I think will work. Because yes, Joy, yes, I am a weight loss surgeon, but I also offer all the other treatments as well. So, I can give you medication. If you want to lose a small amount of weight, there's some very good medications we can give. We can also do balloons. We can also, try lifestyle techniques, exercises. So I work with a whole team of people, and it's really important to, as you said, to work out each patient's journey, to sort of work out, what made them, gain all this weight. But ultimately, what is really important to get across is that excess weight and obesity is not a choice; it's a disease, and it's been recognized by the WHO as a disease. So being obesity is a disease, and once you reach this state, it's important to know there's only very few things that can work to help you to lose weight, significant weight, and long-term weight. Now, your second question, which was about, what do I think about diets? I think diets are good for patients or people who need to lose small amounts of weight. If you need to lose half a stone, yes, I think dieting should be the first approach. But clearly, when you've reached the state when you have a disease of obesity, then we know, and there's so much scientific evidence which shows that diets are actually useless and actually may even be harmful. And in particular, Joy, I'm talking about the kind of, we call them the fad diet. So, for example, somebody only having, I don't know, cabbage soup for 2 weeks, or only having liquids for 2 weeks, or only, doing, a very low calorie diet where they only have, I don't know, 600 or 700 calories a day, or they fast for 20 hours a day. All these are actually very harmful in the long run, because what happens is, of course, you will lose a bit of weight if you have such aggressive dieting techniques. But unfortunately, our bodies are like, they're so intelligent. Your body and your cells realize that you're cutting down the calories. And you know what happens, Joy? Your metabolism slows down. So the body compensates, it adapts. Your physiology adapts to the low calories coming in, and your metabolism slows down. And also what your body does is it fights back. It realizes you're eating much less than what you would normally eat. And people who do these fat diets often feel really, really hungry and really feel uncomfortable. And it's impossible to stay on this really strict diet for more than a few weeks or a few months at best. And then typically, like most people, when the diet eventually stops, they start eating normally again. But now, because their metabolism has come right down, it only takes them a little bit of eating normally, and then they actually go back to their old weight plus some more. and then are putting up more weight than they had before they started the diet.
Yeah.
And it ends up like a vicious cycle of putting on more and more and more weight as you do more and more diets. It's a really, really, a horrible thing to happen. But I see it all the time, and all my patients say to me, "I've tried this diet and nothing works, and in fact, I'm putting on weight." And they're surprised. But actually, when they tell me this story, and it's a common story, I tell them it's not surprising. Don't blame your. This is not your fault. This is not anything that you're doing wrong. It's the physiology. Your body is designed to defend your weight.
Yeah, and I guess that's where the kind of term yo-yo dieter comes in, because people often go on diets and they come off diets and they go on diet, and it's like as you said, it's like a recurring thing, and I think that's something that a lot of people who don't struggle with their weight don't necessarily understand, that you can try as many diets as you want, but you can't live on a diet for the rest of your life. It has to be a lifestyle change. You have to kind of condition yourself to, like, you can't restrict yourself of everything forever. It has to be, I guess, what they say, everything in moderation. But we'll come back to that. Mr. Ahmed, could you explain to us the different types of bariatric surgery that you do or that you know about, for example? So often people hear about the band, the sleeve, and the bypass. Let's focus on those three for now. Could you just give us a brief breakdown on what's the band, what's the sleeve, and what's the bypass for those people that may not know?
Of course, Joy. So, you're quite right. There's actually about a dozen different operations, but the common ones are the ones you mentioned. And in fact, if we were to describe them sort of on a national or even international level, the commonest these days would probably be the sleeve, or we call it the sleeve, but the correct name is laparoscopic sleeve gastrectomy. The second commonest would probably be the laparoscopic gastric bypass. And the third one, which was very common back, about a decade ago, but is now fairly getting less and less common, would be the laparoscopic gastric band, or what we call the band. Let me start with the sleeve first. So this is actually, let me first of all say that all these operations are done with keyhole surgery. So never go to a surgeon who is doing these open, because they should all be done with keyhole or laparoscopic surgery. Now, the sleeve operation is the one that's the commonest one, and it is really very simple indeed. What the surgeon does in a sleeve operation is he basically changes the shape of the stomach and makes it from being like a rectangle into a small tube or a funnel, and you do that by using a special device called a stapling device, and we staple across the length of the stomach, and we end up removing about 2/3 of the stomach, leaving behind a small narrow tube. So that's the sleeve. The gastric bypass is a little bit more complicated, so that takes a bit longer. So whereas the sleeve takes about 40-45 minutes, the gastric bypass would probably take about an hour or an hour and a half. And what we do in the gastric bypass is, again, we divide and we staple off the stomach, but instead of making it into a tube, we make it into a small rectangle. So it's about the size of an egg, if you want to imagine in your head. Obviously, when you eat something, the food has to go somewhere. So what we do is we then connect that egg, that new small stomach, we call it the pouch, we connect it directly to a small bowel. So we bring up some small bowel, and then we do a joint between that small rectangular stomach pouch and the small bowel. And it's called a bypass because we don't remove anything. The remaining stomach inside is still stays inside, but we just bypass it now. So the food is going through, you swallow it, it goes down your esophagus into the new tiny stomach pouch, and then directly into the small bowel, bypassing the old stomach, which is still inside you. It still makes its juices, and then we reattach the bowel coming from the old stomach to the bowel coming from the new stomach. So there's another attachment further down. So that's your bypass. Right. And the third one, which is the band, and that's basically an implant. So we basically put in this artificial kind of, you could call it like a ring or a belt, and we kind of wrap it around the top part of your stomach, and then we kind of make it a little bit tighter, and that kind of creates this new smaller stomach compartment above the band, and then the remaining stomach below it, and it just slows down food from going through, and that's your band. Now the band has a little tube that comes out from it, which is connected to a little disc, which is called the port, and that lies under the skin. And what we can do in people who've had the band is we can either inject liquid through the port and make the band tighter, or we
Mm-hmm.
can remove liquid from the band by, again, putting an injection into the port and then sucking out the liquid and then making the band looser. So we can actually regulate how tight the band is around your stomach, and hence we can also, by doing that, regulate how full and how hungry a patient feels after the band.
Yes, I mean, I've heard a lot of stories about the band, and as you said earlier, it was popular about 10 years ago, but nowadays surgeons aren't really recommended it, especially to NHS patients, I've heard, because I think there's been stories about the band bursting. Can you tell us a bit about that?
Yeah, no, I think, Joy, the band is still an operation is successful when it's done for the right kind of person.
Okay.
The band, if we had to say, which is the safest out of all the three operations,
Mm-hmm.
I would actually say that probably the band is the safest because it doesn't involve any cutting at all. We literally just put the band around the stomach. So it's the safest, and it's definitely the fastest. It takes about 20-30 minutes. And actually, patients who have the band can even go home the same day. They don't even need to stay the night in hospital.
Mm-hmm.
But you're absolutely right. What we have is, in the last 10 years, we've had a series of increasing articles which have looked at patients who've had bands for 10, 15, 20 years. And what people have found, and researchers have found, is that in the long term, probably about a third of bands stop working after about 10 years. And that's the reason why it's become unpopular, is because of this 30% failure rate in 10 years. So it's not really the kind of device that's going to keep going for forever and ever. Although it's designed to stay in forever, but about a third of people who have the band, for whatever reason, can end up with the band failing. So what that means is they put weight back on. So the reason why you put the band in to lose weight, it doesn't work, and people start putting weight back on. So about a third of people end up needing to have more surgery to either remove the band and change it to another operation.
Could they not go back to get the band tightened though? Because you said that it can be tightened a bit more. So after, like, even if it's 5 years or 10 years, if they notice that they're putting on weight, can it not get any tighter, or is there a limit?
No, there's a limit to how tight you can do it, and often you still get this failure of about a third of people, even in people who've had correct tightenings and who've turned up for appointments for their tightening. Even those people, a third of them, the band will just stop working. Usually, the reasons tend to be down to not so much the band bursting, like you said, but more like the band slipping down the stomach, or the band getting infected, or having to have and being removed for that reason, or the band slowly eroding through the wall of the stomach and then becoming inside the stomach rather than being outside the stomach. So these kinds of reasons tend to explain why folks with the band, a third of them fail.
Okay. And a moment ago, you mentioned the band is, might be suitable for the right type of patient. What is the right type of patient for a band, would you say, in terms of size? And what would you say is the right type of patient for a sleeve and for a bypass? Because I think in a lot of programs and things online that you see, people that are a lot heavier, or let's say, I don't know, 500-600 pounds maybe, are more likely to get the bypass than the sleeve. Does it matter? What would you say in terms of that?
Yes, absolutely. So I think it does matter. So the band gives less weight loss than the bypass and sleeve. So just to give you a few numbers, I normally quote the following statistics. So for people who are having gastric band surgery, I will usually say to them that you will lose probably about a fifth or 20% of your weight. Whereas the gastric bypass and the sleeve gastrectomy, most patients will lose between a quarter and a third of their total weight. So between 25 and 30% of their total weight. So the band weight loss is lower. So obviously for people who are not that heavy, the band might be a better option. But obviously the more weight you carry, then you're probably better off having either a sleeve or bypass, because you just end up losing more weight and therefore getting more benefit from the procedure. That being said, the band is a really good device also for people who may be too, they might be too scared of having a bypass or sleeve. They're not comfortable about having a surgery that's going to, alter their anatomy, or they're not happy about their stomach being stapled. So for those people, the band is a good option. Also, don't forget the band is fully reversible. We can always either completely take it out with an operation or empty it by taking all the liquid out. So for people who want to have that I suppose you could say that safety net of having a procedure that's completely reversible, then maybe for them also the band may be a suitable option. So I still see people who come to my clinic asking for a band, and we do bands, and they're happy with it.
Yeah. Okay, that's interesting, and actually leads me nicely on to my next question, which is, what can people expect after surgery? So maybe let's put the band aside, let's focus on the sleeve and the bypass, because often people say, oh, surgery is the easy way out, why don't you just go on a diet, blah blah blah. We've heard it all before, but obviously I'm going through it now. I am 7 weeks out. By the time this podcast goes out, I'll probably be further along, but I am currently on mushy food, so I'm following the diet plan that your team sent me. So can you explain to people what the process is like after the surgery, so in terms of the liquid diet and pureed food, etc.?
Yeah, absolutely. So both sleeve and bypass, the diet plan after surgery is identical, and basically what we recommend patients to do is for the first week after surgery to stick to liquids, and then for the next 1 month after that to move on to mashed food and puree food, and then for the next month after that go on to soft food, and after that, so now you're kind of 2 months after surgery, you can eat anything you want. Obviously you'll feel less hungry and you'll feel full faster, but at 2 months you can pretty much eat whatever you want. Now the reason, Joy, we have this gradual movement from liquids to mash to soft, and the reason for that is when we do these operations, as your body heals up internally, your stomach heals up, it swells. And the issue we have is if we said to somebody after surgery, like the following week, oh, why don't you go and have a piece of chicken or a piece of steak, what will happen is, because there's significant swelling in the stomach, that piece of chicken might just get stuck on the way down and create some discomfort and maybe some vomiting. So to avoid that, we have this gradual change in the consistency of the food over the 2 months once the swelling around the stomach completely settles. So the swelling takes about 2 months to disappear completely. And that's why we also have the diet, which goes from liquids to purees to soft food over those 2 months, so that nothing blocks inside the stomach during that time.
Okay, and I was told as well it's a little bit trial and error, even so after the diet plan, when you can eat everything again, is it a little bit trial and error in terms of how your body will react to certain foods that you used to like, maybe you can't tolerate them anymore? Does that happen often?
It can happen, and it's really also very individual. So I have some people who can eat anything afterwards, obviously smaller amounts, and I have some people who develop aversions to kinds of foods they ate before, but they just don't tolerate it now. What's really interesting, and there's also some good research which shows this, and I think is one of the reasons why weight loss surgery is so successful, is although we're operating on the stomach, we're also operating on people's minds. And I'll tell you what I mean by that, Joy. So it's really interesting, but in this particular study that they did, they basically checked people's preference for types of food before surgery and then a few months later. And they found before surgery, a lot of people enjoyed eating, sweets and high carbohydrates foods. And a few months after surgery, the patient's actual preference when they went was more for vegetables and less sweet foods, more salty foods. And that was really interesting. So you can see how the operation is reprogramming your brain also to go for healthier choices.
Yeah. And it's funny you say that, actually, because as I said, I'm 7 weeks post-op, and what I'm finding is actually because smaller amounts of food and actually healthier food is actually satisfying me. I feel like I'm drawn to that more. I don't know if that makes sense, but it feels like because I've got this as a tool, I feel like I'm more drawn to just having a banana for a snack rather than a packet of crisps or two, which what I would have had before surgery. It's almost like, and the thing is about having more protein and less carbs, it's kind of like, because before the surgery I had to do the no carbs or low carbs pre-op diet, and as you said, it kind of trained my mind to now be like, I always say to people, like my friends that have asked me about it, and they're like, you know, what's it like, blah, blah, blah. And I always say, it's kind of like, you know, how we would have, say, spaghetti bolognese. Now, I would put the spaghetti first, then a bit of sauce on top, and then, you know, some veg on the side or salad on the side. But with the surgery, I've kind of learned that, no, let's put the mince first, and then the veg, and then a bit of you know, pasta. But by the time you've got to the pasta, you're full. And I feel like that is the thing that I'm actually enjoying, is that knowing that I can have, you know, I don't have to have carbs, because carbs used to be a big part of my life, and every meal would contain a lot of carbs, and I didn't even realize it. You know, you just kind of, it's habit, it becomes habit. So I think it does change your train your mind as well. And it's like, you know, you've done all of this work, you kind of don't want to ruin it. What would you say to people that say or think that having surgery is the easy way out? Because I can say it from my point of view, but you're a surgeon. What do you say?
No, it's definitely not the easy way out. I think a lot of people who haven't gone through this, people who don't suffer from the disease of obesity, say this, and I could not disagree more with it. Surgery is not the easy way out. Surgery ultimately is the only treatment we know works for obesity. There have been so many studies that have taken you know, people suffering from obesity, and they've tried different treatments. They've tried lifestyle changes, they've tried dieting, they've tried medications, and none of these things work to treat the condition of obesity. Only weight loss surgery has been proven scientifically to actually make a big difference to treat obesity, to reduce obesity, and also to reduce the health problems that come as a consequence of being obese, and also reduce the likelihood of developing health problems in the future. Also improve life expectancy back to its normal, and also reduce the risk of cancer. So something that a lot of people don't know, Joy, is that when you carry excess weight and you're obese, you have a 40% higher risk of catching a cancer or developing a cancer, specifically breast cancer, uterus cancer, ovary cancer, and colon cancer. All these cancers are related to obesity, and we know there's a strong association. And we have got research which very nicely shows that when people who've had obesity have weight loss surgery, their risk of these cancers drops right back down.
Yeah. And I think as well, it's funny because a lot of people just assume that, you know, because you're overweight or obese, it's just because of what you eat, and there can be no other factors. But I've seen in a previous interview that you've done that you said that you believe that obesity is in your genetics or part of your genetics. What could you speak on that a little bit for me?
Absolutely. So there's very good evidence now that more than your environment, it's the genes that basically determine whether you become obese or not. And it doesn't just mean genes like your mom and dad. It could actually go up many generations, and it could skip generations. So you could have skinny mom and dad, and even skinny grandparents, but maybe, you know, older than them might be you know, other family members who've had obesity. So it might skip generations. But we know now, I would say that probably 70% of obesity is genetically determined. And what the genes do is they don't just make you obese, but what they do is they create what's called a genetic susceptibility to developing obesity. In addition to the genes, we also have another phenomenon which is called epigenetics. Now that is something very interesting, and it's about what your mom ate when she was pregnant with you inside her womb.
Okay.
What's really interesting, Joy, is that what mom ate when she was pregnant with you in her also affects your risk of developing obesity and diabetes. And so that you have genetics, you have epigenetics, and then yes, you have environment as well. So you need to have all these three things that work together that eventually end up with causing obesity. When it comes to the environment and what you eat and drink, yes, obviously that plays a part, but a lot of it is already being pre-programmed by genetics and epigenetics. A good example or a good analogy, Joy, would be to think of, I guess you could think of a pistol. And what the genes and epigenetics do is they kind of load the gun. And then so you have the gun is loaded, and what you need then is the bad environment, the easy access to bad things, fast foods, high calorie foods, and that triggers the gun to shoot, and then you develop obesity. So that's the kind of analogy to look at.
Yeah, no, that's interesting. And I guess following on from that point, you are a surgeon for the NHS and you also have a private clinic as well. NHS and their kind of, I guess, the what's the word? The process of getting bariatric surgery is fairly long, in my opinion. I think roughly it's 2 to 3 years, maybe. And that's from from when you are, go through your GP to get referred and so on and so forth. What do you think about that length of time? Do you feel like that is acceptable, or do you feel like it needs to be improved? I know that there's obviously issues of funding and things like that, but do you feel like bariatric surgery should be more easily available to people?
Absolutely, without a doubt. And it really, I'm also on the council for the British Obesity, and Metabolic Surgery Society, and we try so hard to change this. And unfortunately, the problem boils down to money and how much money the local health authority has to pay for people's health problems and how they prioritize that. And unfortunately, there is so much anti-obesity feeling out there that people who suffer from obesity, unfortunately, they fall at the bottom of the queue, and that's why not enough resources are given to treat obesity, and we keep fighting this because if you treat obesity with weight loss surgery, you don't just fix obesity, but you fix all the other health problems that would normally cost money to help to treat anyway. So with one procedure, you fix everything from diabetes to high blood pressure to heart disease to people needing hip and knee replacements. You fix so many different problems. Yet, we're facing that battle where we have to convince health authorities to invest more money, to make more bariatric surgery units, to refer more people for bariatric surgery, because it will really help our NHS, if we could go through and help more people. Just to give you some figures, the last time I checked, there are about 2.3 million people in our country that meet the criteria for bariatric surgery. And I can tell you, obviously because of COVID now, our numbers of surgery are lower, but before COVID hit us, we were doing at most about 6,000 operations a year in this country for weight loss surgery through the whole country. And we have 2.3 million people who need the surgery. I mean, it's astounding.
Yeah, it sounds it. And just touching on a point that you just made there about people that meet the criteria, what is that criteria? Could you tell us? Because some people may not know, and they may be sitting at home thinking, oh, do I meet the criteria? So what is, because I know they go by BMI and everything like that, so can you talk to us about that?
Absolutely. So if you want to have bariatric or weight loss surgery in the NHS, there are a certain set of criteria. We call them the NICE criteria. That's NICE, which stands for National Institute for Clinical Excellence. So the NICE criteria are basically based on your body mass index, or we call it the BMI. And that's basically your weight in kilos divided by your height in meters, but you square that. Okay? So normal BMI would be between 18 to 25. Between 25 to 30, you would be considered overweight. and anything over 30 would be considered obese. Now, to be eligible for NHS bariatric surgery, your BMI has to be over 40 if you don't have any health problems.
Right.
However, if you have obesity and let's say, arthritis in your knee, then they will reduce the threshold to 35 BMI.
Right.
Okay, so if you have obesity and a health problem, the threshold to be eligible for bariatric surgery drops to 35. If you have diabetes, type 2 diabetes, and only type 2 diabetes, and then your BMI threshold drops further to 30.
Okay.
If you're a type 2 diabetic and your BMI is 30 and over, then you'd be eligible for NHS bariatric surgery. But like you said, the waiting lists in the entire country are now completely out of control. I mean, they were long anyway before COVID, and now with COVID, it's really messed it up big time. So
sorry, can I ask, do you have to, is it the same criteria if you want to go private, or do the numbers change there?
Depends really. With privately, we have probably a little bit more flexibility to help our patients, and it's really based on an individual patient. So I see each patient individually and discuss their case with them and make a case for surgery if they don't meet the threshold exactly. So we have a bit more flexibility privately, yes.
Okay. And although, like, I wanted to get you on here to kind of just tell us the facts, you know, because you're a professional, I'm not, I'm just, you know, living through it. But what would you say to anybody that may be listening to this, that may be considering surgery, but have never really, you know, had any of these questions answered, maybe? Because we know there's Google, but there's also, you know, lots of rubbish on Google as well. So I feel like it's good to come from somebody who knows, you know, exactly what they're talking about. So what would you say to someone who may be thinking, I kind of want surgery, but I'm a little bit scared. Maybe they've never had a surgery before. Maybe they're scared about going under the knife. What would you say to them? Not that we're trying to encourage them, but this is for people that are already, you know, 80% there.
Yeah. No, I would basically say to them, don't be afraid. It's the surgery, when done correctly by properly trained surgeons, it's extremely safe. It's one of the safest kinds of surgery you could do. And we know now from various studies that the risk of a complication, from weight loss surgery is like the same as having your appendix taken out, or a knee operation, or a gallstone operation, when done safely. So it's a really safe operation. So I would encourage people, don't be frightened of it, don't be safe, make an appointment to see a specialist. And I would also encourage them to go for it, because the longer you live with obesity, the more likely you are to develop health problems, from it. There's no advantage in waiting to have surgery. If you feel like if you think you need it and you meet the criteria, come and see it. Go and see a specialist, come and see me or whatever, just so that we can discuss it and do it so you can enjoy the rest of your life.
Yeah, and I feel like that's the thing. It's a case of, what are we actually waiting for? Like, I think that's why, I came to see you in the end, because I was like, I just didn't want to wait 3 more years, of more than the 2 I'd already waited. So yeah, I mean, it's everyone's personal choice, and I feel like people just need to understand that you got to do what you want to do what's best for you, and just not worry about what everybody else has to say. And there's a lot of people actually that have had surgery that you wouldn't even know. People don't always talk about it. People have surgery and they keep it quiet, but I wanted to be very transparent and tell people, no, this is what I've had. It's a part of life. I'm not ashamed of it, because I think as well that's a big thing. Sometimes people have surgery but they're ashamed because sometimes people may feel like it's a failure. My last question to you, Mr. Ahmed, is going to be this. We spoke about diets earlier, and we said how, maybe for 2 weeks or a month you want to lose a bit of weight. Surgery to me was more of a long-term goal and a long-term achievement. Can you speak about that? What are people's success rates, if we can call it that? How are people 10 years out, 20 years out? do people ever go back to the size that they was when they started?
Yeah, a great question again, Troy. So the answer to your question is, and in fact, the question has already been answered. We have, again, some really good data and scientific studies which have looked at exactly what happens 10, 20 years after surgery. So, and this is in everybody who's had weight loss surgery. So to give you an example, if we start at somebody's weight, let's just say for the ease of mathematics that they weigh 100 kilograms, right?
Mm-hmm.
At 100 kilos, in the first year, if they have a sleeve bypass, they will lose about 30% of that. So in the first year, their weight will go down from 100 kilos to 70 kilos. Okay. Now, what will happen in the next 20 years is that 70 kilos, it won't stay at 70, because as time goes by, it is just normal physiology to gain a little bit of weight as you age. And even surgery can't reverse that. It's called physiological age-related weight gain. So over the next 20 years, your 70 kilos will slowly go back up to about 80 kilos 20 years later, but it will never go back to 100 kilos. So the answer to your question is, weight loss surgery provides significant weight loss and long-term weight loss. Will you be exactly the same weight 20 years later from what you weigh a year after surgery? The answer is no, but that's just normal human biology. You will regain a little bit of weight, but you should never go back to your original weight.
Yeah.
Okay.
Yeah.
So that's the sort of the message I want to get across.
Perfect. Thank you. Well, we have come to the end. Obviously, you're new to my podcast, so you don't know this, but everybody that comes on my podcast as a guest, I try to get them a gift to say thank you for giving up your time. When I was in the hospital, you told me I had to drink lots and lots of water. So since I've been home, I've been drinking lots of water. Now I was thinking, what can I get Mr. Ahmed as a gift? I'm pretty sure you've got everything that you need. But I thought, when you're not, cutting people open, you might be in the office and you might need a cup of tea or coffee. So I've got you a personalized mug that says Mr.
Wow.
Ahmed, world's best bariatric surgeon, and on the back it says "as voted for by Joy's World," the podcast.
Amazing.
So I'll bring that to you in my next appointment.
Thank you so much. That's amazing. I love it. Thank you very much indeed. Very kind of you.
You're welcome. Thank you so much for joining me and speaking openly and freely about this. I feel like it's going to resonate with a lot of people. And as I say, this is not an advert for surgery. I just wanted to get, a professional's opinion. And, if people want to contact you, you are very high up on the list on Google. When they Google bariatric surgeons, you come up, so you must be doing a good job. Guys, thank you so much for listening to this episode of Joy's World, the podcast. Remember to stay happy and live your best life. Always remember to follow your dreams and follow me on Instagram at Joy's World, the podcast. Follow me on Twitter at JoyXOXO. Email me joyspodcast@hotmail.com. Mr. Ahmed, thank you.
Thank you very much, Joy. Take care.
Bye.
Bye-bye.